Good evening, everybody. Today is Tuesday, October 5th, 2021. Today is a case list defense webinar. Before we start, can I have it with a raise of hands? Can you hear me? Is the audio working okay? Can I have a raise of hands that you hear me okay? Okay, thank you so much. I'm going to put everybody's hands down. Before we start, does anybody have any questions about anything? Anything in regards to the exam, anything in general you've heard in other webinars? Just looking down the list here. Okay, I see nobody has any questions. Does anybody want to be in the hot seat to participate? Hopefully everybody on the call has submitted their list to the office, so it'll be in our file. Anybody interested in being on the hot seat? I'm going to Jaylene. Can you hear me, Jaylene? It says you're self-muted.
Yes, I can hear you.
You can hear me? Awesome. You turn in your case list?
I did.
Okay, let me go ahead and I want you to see my screen turn black here in a second. Any questions while I'm looking for?
Nothing in particular. I
Okay.
think the list that I'm most nervous about is probably my office list. So
Okay, you want to work on the office? All right.
Hurt me there a little bit.
Okay, we can do that. Any particular case?
No, you do. You pick what you want on there.
Okay. Okay. Are you a generalist?
I am.
You are, okay. I have clicked on it. Lately, it's been running slow, so bear with us again. Also, if I lose you guys because of Wi-Fi connectivity, just stay on the line. I will get back on. Looking here, I don't see your GYN list. They have the OB and the office, just letting you know if you want to submit that to the office.
I can send it again.
Okay.
I just put them all in the same email. Thanks for letting
That's what I'm looking at here. Yeah.
Okay.
I'm just looking down the line here. Case number 10. Can you just discuss this case for me?
Okay. This was a 36-year-old G1P1 that came to the office with menstrual cycles that were every 3 to 4 months. And she's interested in having another baby. And she's trying to figure out, okay, so what's going on? Why am I not getting pregnant? And so we performed, well, I did a history and a physical. So that's how I learned that she was having menstrual cycles every 3 to 4 months. And she had no history of like PCOS or anything like that in the past. No history of.
So saying that you brought up PCOS, what is the Rotterdam criteria for PCOS?
Yes, the Rotterdam criteria is signs of anovulation, meaning irregular menstrual cycles. That's one. And then 2 would be signs or laboratory evidence of androgen excess or hirsutism. And then the other would be ultrasound findings of a volume of 10 meters squared on ultrasound, or at least 12 or more antral follicles noted in the ovaries, and you need to have 2 to 3 of those, or two of 3.
Okay, continue your discussion with the patient.
So I performed an ultrasound. Excuse me.
No, just continue in regards to this patient. in your
Okay.
evaluation?
Okay, we did an ultrasound and she had multiple fibroids, and the lining of the uterus was distorted due to fibroids, and then her ovaries appeared normal. I did an FSH and an AMH along with a TSH and a CBC. I just kind of put the more pertinent information here. Those other two were normal. And her FSH was 50 and AMH was less than 0.15. And so I discussed with her premature ovarian failure. And I sent her to the reproductive endocrinologist. But prior to that, I discussed with her the option for donor eggs, given the fact that at this point, so sorry, prior to this, her periods were 3 to 4 months. At the time that I had seen her, she probably hadn't had a period for about 6 months. And so, anyways, that's what actually prompted me to go ahead and get those labs. And
Now,
so
what is the definition of premature ovarian failure?
Menopause before the age of 40.
Is amenorrhea a requirement?
Amenorrhea?
Yes, it's part of the definition.
Yes.
And what other testing is recommended for somebody that has premature ovarian failure?
Labs that would describe why someone would actually have gone or would have amenorrhea, so maybe a PRL. We can get a DHEA.
What do you mean by PRL? Prolactin?
Yeah, sorry, yes.
Anything specific for somebody who you believe has premature ovarian failure?
As far as labs are concerned?
Are you still with me? I just want to make sure I'm not losing, because I lost the audio there for a second.
Yes, I'm still here.
Okay.
Are you referring to labs?
Yes, imaging studies, labs that are usually recommended to somebody that you've diagnosed with premature ovarian failure.
Okay. I'm interested in looking this up a little bit more, and I can get back to you.
Okay, no worries. So should you be concerned that she could become pregnant even though she has premature ovarian failure?
Yes. Because even though her labs show that she's probably no longer making any or no longer ovulating, here and there you may have ovulation just intermittently.
And what did the REI specialist recommend for the patient or discuss with the patient?
Discussed egg donor option. That was pretty much it.
Anything else? Do you know that he or she recommended?
Now,
can you tell me, because she's in your infertility, yes, go ahead.
He just mainly talked to her about egg donor option.
Say that again, I'm sorry?
I'm sorry?
Okay. No, I lost you there for a second. Seeing that she's in your infertility category, can you discuss for me just your basic infertility workup for a patient? When you would do an infertility workup, what would you do in the infertility workup, and so on and so forth?
Okay, so for a person that's under the age of 35, after they had been trying to get pregnant for a year, I would, of course, do a history and physical, learn about their menstrual cycles. I want to know if they're regular, because that would help me determine whether she's ovulating or not. I would like to know if she's using maybe like a period tracker, make sure she's having intercourse during the ovulatory period, see if she's used an ovulatory kit in the past, and if it's shown her that she in fact is ovulating. I want to make sure that she's actually not using birth control or condoms. Sometimes you have to spell those things out to patients, and so I just try to make sure that I'm thorough from that regard. And then I would perform an ultrasound to see, I would also want to know if the partner has fathered a child before. I want to know if she has had a child before, and maybe how long it's taken for her to get pregnant the previous time. And I would perform an ultrasound to see if there was anything like distorting the endometrial cavity, any issues related to dysmenorrhea that could lead me to endometriosis.
So let me interrupt here for a second. You said you were doing an ultrasound to see if there's anything distorting the endometrial cavity. Would
Yeah,
that really lead to infertility in itself?
it could. Say the person is actually getting pregnant but not able to implant because there are fibroids distorting the cavity.
So would she ever have gotten a positive pregnancy test in those situations, or it was too early for her to know she was pregnant?
Both. It could be both ways.
Okay. And how often is it recommended to take somebody to the operating room? Let's say she had an intramural fibroid that abutted into the endometrial cavity, and she's unable to become pregnant, or she has miscarriages, to say she needs to go to the operating room because that fibroid is causing an issue.
Okay. Like you said, intramural, so more like a type 3?
Type 4, type 3, 4.
For a type 4, I probably would not, given that it's 100% intramural and it's just like not necessarily touching the cavity. For a type 3, that's really only touching the endometrial cavity, so probably not. I would more so take a patient to the operating room for a hysteroscopic myomectomy in the setting of a type 2 or type 1 or 0 fibroid.
Mm-hmm.
Because
If
those
she
are
had a
more
history of
to distort the
miscarriages,
cavity.
infertility.
I'm sorry?
If she had a history of infertility / miscarriages.
A type 4, I would not. I mean, it's not
No, you're talking
necessarily.
about for 0, 0, 1, and 2.
Oh, yes. For
Yeah.
those, yes, we
Okay.
would. Yes.
Okay. So continue with your infertility workup.
Okay. I would also get a TSH, potentially a prolactin, depending on things related to her history, and kind of go from there. For someone who is greater than 35, I would do all the same things, but start the workup at 6 months.
And so let's say she has regular periods, all her blood work is normal. What else would you do in your workup?
Um, I think you can never go wrong with sexually transmitted infection testing, but not necessarily for infertility. But I'm sorry, I'm just coming back and just saying that that's something that I could test at the beginning.
Mm-hmm.
But after the labs are normal, ultrasound normal, I would consider my workup to be pretty close to complete, and I would probably do something to help with ovulation induction.
So is there any other things you can do to evaluate why a patient's having difficulty getting pregnant?
Oh, I'm sorry. Yes, there are. You can do like progesterone and estrogen levels. Like you can do a day 3 estradiol.
Anything else?
I'm also interested in looking that up, and I can get back with you.
So in essence, they will not give you any feedback in the exam. So I'm going to prompt you here. You're
Okay.
focusing on all her labs. There's other things you got to focus on. What are the causes of infertility? You're
Okay.
forgetting the male factor, correct?
Oh, sorry. Yeah, he needs a
Mm-hmm.
semen analysis.
And then what other factor in the woman that you should focus on as well?
Well, I looked for structural abnormalities with the ultrasound, and we talked about history. So, like, say this person has never had anything. We talked about infectious
Let's say she has a history of past PID. What are your concerns?
adhesive disease or inflammatory things in the pelvis to where
Leading
the
to?
be open, so like an HSG, so more.
Exactly.
Yeah.
Exactly. I'm
Okay.
not saying all the lab work that you discussed was not correct, but also do not forget your male factor.
Yes.
And you know, you can give her as much ovulation induction as possible. But if her tubes aren't patent, it's not going to be of any value.
Right. Okay.
Okay. Other questions?
Not right now. I mean, I just know that this is my list that I have to really, really.
So let's focus on premature ovarian failure. Okay.
Mhm.
So women younger than 40 with irregular menses in association with an elevated FSH. The presence of amenorrhea is not required, as
Okay.
women frequently have intermittent ovarian function and spontaneous menses. This is as per up to date as well. Because of that, if she does not want to become pregnant, she should be on some type of contraception. But yes, also on the flip side, you know, you want her to have some estrogen, you know, to kind of protect her bones and those type of things, right? So those are
Right.
some of the other things, and then I'm going to tell you about that you should be focusing on. So when somebody has premature ovarian failure, you should do a primary adrenal insufficiency evaluation. Your test for adrenal autoantibodies. Development of irregular periods precedes development of adrenal insufficiency by several years. So if somebody gets adrenal insufficiency, you got to treat that because it can lead to problems. Evaluate for autoimmune diseases, Fragile X syndrome. You do a karyotype because you could be a mosaic, right?
Mm-hmm.
And you test for the FMR1 permutation because 14% of women with familial premature ovarian failure we found to have the premutation.
Okay.
Okay. And a DEXA scan should be obtained as a baseline,
Okay.
right?
Yes.
So
I actually
that's
thought
from
about
up to
that
date.
and was like, oh, but that would be my
Say again. I'm sorry.
therapy. Okay.
Say again. I'm sorry.
I was saying I actually thought about that and then I was like, no, she's asking for like how else would I like evaluate? But I guess that is a yeah, I'm mixed up
Exactly.
a few
So
things.
yeah, you proved the. I mean, you would hope the REI would do that, but you'd be surprised. I'm sure that they're focused more on trying to get her pregnant.
Mm-hmm. Okay.
To my understanding, and I could be wrong, I'm not a specialist, I'm just a generalist, but to my understanding, um, if like to do a myomectomy, I'm not saying a type 0 or 1, but to say you need a myomectomy because you're having miscarriages or infertile, that's like last, you have to rule everything else out. That is not the first on the list, to my understanding. I'm not an REI specialist, but that's not the first on the list to say, yeah, you're having you have infertility, you're having miscarriages, you need a myomectomy. I can't speak specifically for 0 and 1. What's more specific in regards to miscarriages would be like a bicornate uterus or like a septate uterus, where you know the pregnancy can implant in the septum, and the septum is avascular, so that's why you miscarry.
Okay.
So if you want to double check that, because the way you worded it, I was like, um, in, that's something that's last on the list for treatment if somebody's having issues with infertility, or unless, let's say, there's some fibroid impinging on like the ostia or something weird like that.
Mm-hmm. Mm-hmm. Okay.
But that's not first on the list, so to speak. Not first on the list. Um, Other questions?
Nope. Thank
Your
you.
Rotterdam criteria was correct. It's greater than 12 cysts, 2 to 9 millimeters in size, or 10 cc volume in either ovary. So you were correct in that, 2 out of 3. Anything else?
Nope, that's everything.
All right. Well, very good. Good job. We'll take you off the hot seat. Great
It's
job.
sure
Thank you
hot
for
too.
participating. I know it's hard. It's hard, but you did good. You did good.
Thank you.
All righty. All right. Anybody have any questions in regards to, I'm going to turn off my screen for the next person here. Any questions on that topic? Okay. I don't see anybody having their hand up here. Anybody is interested in being on the hot seat? Erica, I'm heading your way. It says you're self-muted.
Hello.
You there?
Yes, I'm here. Can you hear me?
I can hear you. All right.
Wonderful.
You turned in your case list?
I didn't submit a case list. I thought these were random questions. Sorry.
So you do not have a case list submitted?
I don't have one submitted to you all. I guess I could do it next
Okay,
week.
no
I'll
worries.
put my hand down.
What are you interested in a particular? We'll use somebody else's. How's that?
That's fine.
Are you interested in a specific section?
No, surprise me.
Surprise you. Hmm. I'm just looking. Bear with me. Are you a generalist?
No, specialist.
What do you do?
REI.
Oh, dude. So is that correct in regards
Yes.
to the fibroid?
Yes, ma'am.
In your infinite wisdom, please fill this in as I'm looking for a case. How's that?
I
So
mean,
maybe
it
I
was
do know something.
perfect. I mean,
It was? Oh, great. Can I
we
get
do
the
obviously
bucks
straight
now?
for the fibroids. We'll remove them just before we do transfer, but obviously, I mean, it's not our priority. It's not a reason for infertility, but it obviously would cause miscarriages. But everything was good. She
And
did a good job.
she did a good job. She did. And anything else you would add in the premature ovarian failure?
No, I think that was perfect too, as far
Yeah,
as
that I
like
got that straight from Up to Date, which makes
it was
sense. We
fine,
we get
yes, of course, our first job is like, well, how are we going to get you pregnant? But yes, do take and do a
right.
DEXA scan and do hormone replacement therapy for your bone health. So, and then I always send them to a general endocrinologist who can maintain them for the rest of their duration. But spontaneous conception, I always tell them that is something that can still occur. So, do take birth control if you're not wanting to be surprised.
And I know when I was a resident, it was recommended, this is many years ago, 20 years ago, so that's completely changed. They had to be on combined oral contraceptives because they felt they needed to be on the higher estrogen dose. And to my understanding nowadays, it's any type of hormone replacement.
Yeah, any type. I still tend to use
Yeah,
birth control just because I still want to get the progesterone and protect them just in case.
right,
I was
exactly.
worried about endometrial hyperplasia.
Right, but in the old days, they thought you had to get a higher dose of estrogen compared to what you would get with the hormone replacement. But now either
Mm,
or, whatever the patient's looking for.
yes, ma'am.
So you see my screen there? We're
Yes.
actually going to be talking about case number 114.
Okay.
So how do you know when you're doing a delivery that you've encountered a shoulder dystocia?
Um, I know that I can count or suspect I have a shoulder when that's classical. I see a turtle sign with baby. She's pushing. Baby head is coming, but it's still not descending. It's doing that kind of retracting and coming forward. That's my first kind of worrisome stage, and we've been doing this for a while. So then at that point, I start to suspect and get my team prepared.
So tell me exactly what you do in regards to when you have a shoulder dystocia.
The first thing I do when I'm assessing is have mom stop pushing. I just notify my nurse who's in the room to kind of lower the bag, notify like the rest of the team that I think I have a shoulder. And at that point, I start feeling to assess where, if I can with my fingers, to see where is the shoulder in relation to like the head presentation. Is it anterior or posterior, which way the baby's facing? And then at that point, I just get mom prepared to do my maneuvers, which the first for me is to put her in McRoberts position. After she
So
gets
what's
in McRoberts, well, you have the legs hyperflexed, and have mom not push at all until we get her in that position.
So let's say you do your McRoberts and the baby doesn't come. What would you do next?
With the McRoberts, if the baby doesn't come at that point, I then try to have her stop pushing again. I assess if I can do suprapubic pressure with that, not fundal pressure with the pushes. Additionally, I try to see if I could deliver the posterior arm. And so with that, I take my hand and try to assess and see if I can grab and sweep the arm forward to deliver the posterior arm, and then have her try to push on that attempt.
So let's say you can't get the posterior arm. What would you do next?
If I can't get the posterior arm, I don't know if I can't get it because my hand's kind of big, or is it because I'm just not getting it. But there is a new procedure where you can take and I've never done it, but you could take a Foley catheter and try to do a sling around the baby's arm and then try to deliver it posterior. That way, if that is still not working, and I think it's a spatial issue, and I know it's not because of the episiotomy doesn't help because of the shoulder distortion, but it may help me with my hand placement, then I do assess if that's what the issue is. And if I need to cut a episiotomy to help me better maneuver to get the baby's posterior arm delivered, then I would attempt that too.
So let's say you do your appease, you can't put a little Foley in there. What other maneuvers can you do?
Then you have the wood screw maneuvers where I can place my hand on the posterior shoulder of the baby and my other hand anterior and try to twist the babies, rotate the shoulders 180 degrees to see if that would dislodge the shoulder, and then have mom to push at that point to see if we get descent of the baby.
So let's say that doesn't work. What would you do next?
If that still is not working, then there is the midwifery position where you can put mom in the all fours to see if we can get baby to deliver that way. If all these other maneuvers haven't.
So let me stop here a second. So you put her on all fours. What would you do at that point when she's on all fours?
When she's on all fours, I still at that point then try to do my same maneuvers again, deliver the posterior arms with her in that position, and then have her push to see if baby would descend.
So if you're going to be applying pressure, would you be applying it downward or upward?
If I was going to be doing pressure, I would do it upward in that perspective because her pubic is now down and her rectum or buttocks is up.
So let's say that doesn't work. What would you do next?
If that doesn't work, I would put baby mom back in her supine position. And at that point, I'm starting to think about other maneuvers, and those maneuvers would be if I've done wood screw, corkscrew, McRoberts, and nothing's working. Then we're kind of getting to those stages where I do things that is invasive for baby and mom, and that might be breaking the clavicle for a baby to see if I can then, after breaking the clavicle, can then have her push and have baby descend.
So how do you fracture the baby's clavicle? Can you explain that to me?
So I hook my finger and I pull upwards away from baby because I don't want to go into the vessels, injure baby, and try to break the clavicle there at that point.
So let's say that doesn't work. You still have a shoulder dystocia. What would you do next?
At this point, if all these maneuvers haven't worked, I do have notified my pediatricians and anesthesiology, and I'm probably going to ask that we start moving things towards where we're going to the operating room, but not quite yet. I can still do more invasive things for mom. And so I've tried with breaking the clavicle. So at this point, you can do things like the pubic symphysis dissection of mom, which, you know, I don't want to do, but if I'm trying to get this baby delivered, that's my next kind of last ditch, one of those last ditch efforts that I
So
would attempt.
explain to me how you would do that. So you're saying you would transect the pubic symphysis? Is that what you're telling me?
Yeah, so you first put in a Foley catheter for mom so you know where the bladder is so you don't do any injury to the bladder. I have never done one, but from what I understand from my reading is you would have your hand sweep the bladder to the side because you know where it is with the Foley bulb in place, and then you would take any sharp instrument, scalpel, put your hand over the baby so baby's not injured, and you would cut upwards and not towards the baby in order to try to dissect or displace the pubic bone so that now we have a baby with a broken clavicle, mom pelvis is open, and then have her try to push to see if now this baby could be delivered.
So now we're going to change gears. Can you tell me what the definition of postpartum hemorrhage is?
Postpartum hemorrhage is greater than a liter of blood loss, whether it's vaginal or C-section. And that can, yes.
Anything else?
That's postpartum hemorrhage, but we still obviously, I'm old school. When I trained, it was 500 cc's for vaginal delivery. I still would also be on high alert in the vaginal, even though our definition has now become a liter. But also you could look at the number of sponges and things that you've weighed to kind of gauge if you are in a hemorrhage situation. Postpartum hemorrhage, it could be immediate or it could be delayed. Postpartum hemorrhage could be after delivery, even a week later, as late as that. But those are the definitions for postpartum hemorrhage that I'm aware of.
And what increases your risk for postpartum hemorrhage?
A grand multip, a multiple delivery, things that cause uterine atony. So if she's had chorioamnionitis or any infection during delivery, macrosomic infant or fetus is also a risk factor. Those are the ones that I can think of at the moment.
So let's say you're able to deliver the patient's shoulder dystocia, she delivers, and you encounter a postpartum hemorrhage. How would you evaluate that?
So for her, because she was a very traumatic delivery, I would want to be in the operating room because I would have better lighting, but I would assess first to make sure that the uterus, there's no retained products of conception, which would be another reason for hemorrhage. So sweeping, doing a bimanual massage, sweeping and seeing if I feel any membranes. Also making sure that we did thoroughly inspect the placenta after delivery, that there was no missing lobes and everything's intact. That would be my first step, as well as looking at the vaginal wall, the cervix, or any other area. Obviously, with this, I don't know if it's the same patient that we just did the shoulder dystocia. She's going to be bleeding because I cut her pubic symphysis. But those would be my first initial steps, is to see if I see any lacerations or things that could be repaired outside of having retained products that I could be removing and evacuating while I'm doing bimanual massage and axing to make sure that she has her Pitocin open and wide running.
Just in general, is there any other causes for postpartum hemorrhage?
Other causes, so retained product subinvolution and inverted uterus can give you that. The lacerations, as I mentioned, and then those other things that increase atony, such as, and I think of them as the M's, multiples, macrosomia, infections. I'm sure I'm missing something, but those are the ones on the top of my list.
So let's say the patient has uterine atony. Can you just quickly go over the different medications that are available, their dosing, route of administration, frequency, contraindication?
So medications, well, now its first line is Methergin and not Cytotec, even though I like Cytotec. But Methergin can be given, I think it's 0.2, and that's IM.
0.2 what?
Units, I'm not quite sure on the units anymore, but milligrams.
Okay, continue.
Methergin, Cytotec, which can be given rectally.
So let me go back to Methergin. How often can you give them Methergin?
Is it every, I think it's every hour, but I'm not sure on that.
And what's a contraindication?
Hypertension.
And what was the route of administration?
I said IM.
Okay. And then you said Cytotec?
Then
What's
I
the
said
dosing on
Cytotec.
that?
So you can give 1,000. It could be
What are the 1,000 what? What are the units?
milligrams.
Okay.
That's given, could give, and typically for postpartum hemorrhage, I give it rectally, but you can give other forms, but that's usually not for postpartum hemorrhage. Then you have
How
hemabate.
often can you give it?
In a postpartum hemorrhage, I believe, well, you wouldn't do 1,000 again, but typically I know you can give it every 4 hours, but that's not 1,000.
Any
So I'll
contraindication?
have to review Cytotec. Well, I know it can cause fever, so I think, the contraindication is just kind of if there's already some infectious process, I probably wouldn't use it, but otherwise, no, when you're giving it rectally.
Any other medications?
Hemabate, it can be given in hemabate. I'm not sure the dosing, and asthma will be a contraindication.
And what's the route of administration?
You can give it IM.
How often?
I don't know the dosing time or frequency.
Any other medications?
You can give tranexamic acid. Don't know that, I've never used it, so don't know the dosing or the route for that.
Anything else?
No, not to my knowledge.
All
Pitocin.
right, let's stop.
Obviously oxytocin.
Well, there you go.
That.
I was waiting for that one. All right, let's stop there. Very good. All righty. In regards to your shoulder, you never say symphysiotomy, ever.
Never? Even if
Never,
the baby's
ever,
dying? Okay.
You're supposed to, well, if I'm not mistaken, the Exam Pro manual says under no circumstances should you, if I believe that's what it says. I know my manual says that. My manual's a few years old. But it's a big no-no. I know in some third world countries where they don't have access to operating rooms like we do here. I know they've done it in third world countries, but this is America. That is not an option that's offered. You rather go and do a Zavanelli and take the patient to the operating room before doing a symphysiotomy.
Okay, because I went to the Exam Pro class and somebody did and they never told us not to. So okay, well I'll take it off my list.
Okay, well that I know when I took the exam, it was a big no-no.
Okay.
I don't know if something's changed. And I actually know for a fact that when you do a symphysiotomy, usually the pelvis just opens up and the baby just slides out. Because I know a baby that got stuck and it was 10 pounds, and that's how they got the kid out.
Okay, so no, it's good.
But I'm not supposed to be saying that's what you're supposed to do. It's supposed to be a big no-no.
Okay.
And what are the chances of knowing somebody in my residency, one of our attendings, he had experience doing that because he was from a third world country. So
okay, so we'll take it off the list.
So, but if you want to double check, but to my understanding, my Exam Pro manual says never do the symphysiotomy.
Okay.
But all your maneuvers were correct. Perhaps you could have run back to the OR quicker. Supposedly, when you're doing the Gaskin maneuver, that's like literally when everybody's moving to the OR, you're on the bed with the patient trying to do the Gaskin and pushing up.
Okay.
You always push up towards the ceiling because the lady's backwards. So that's like a
Right.
last ditch effort as you're moving the patient to the back to do a Zambinelli maneuver.
Okay.
But I thought you did good with all your maneuvers and all that stuff. Okay, in regards to your, I was waiting for your uterine inversion. You didn't say inversion, that you would evaluate the patient for an inversion. So that's why I said, is there anything else that causes postpartum hemorrhage? Okay, so Methergin is 0.2 milligrams IM every 2 to 4 hours. Contraindications, hypertension. Cytotec is 1,000 micrograms per rectum times 1 dose. No contraindications. Hemabate is 250 micrograms IM every 15 minutes for 8 doses. Contraindications, asthma. Tranexamic acid does not treat the acne, but hopefully to control bleeding. It's 1 gram IV. If the initial medical therapy fails, it works best if used within 3 hours of the delivery.
Okay.
Okay. Do
Thank
you know
you.
what the dosing of Pitocin is if the patient does not have an IV?
Oh, no, I don't, but I know you can do it. I am.
Yeah, it's 10 units.
Yeah.
IM.
Thank you.
Do we have an MFM on the line here? I'm trying to look down the line. I know we have some MFMs here, I'm sure. We did last month. I'm going to lower everybody's hands here a second. Is there an MFM? Please raise your hand. Because I want to see what they say in regards to the shoulder dystocia. No, no MFMs. Darn. So somebody's wrote here that Dr. Shamroth spoke of symphysiotomy when he did RMARC oral. When I did the exam pro, this was over 8 years ago, that was a no-no. I could send him an email, see what he says, but, and then I have Dr. Martinez saying, I thought gasking was many for midwives. I don't know what that means. Oh, mainly for midwife. Yeah, but you could still use it. It's that, there's no harm. And as you're running a patient to the back to get her ready to go to the operating room to do a Zambinelli, I mean, it's just and a lot of people say it works. A lot of people say it works really nicely. So it's a midwifery trick that works. So you do whatever works, right? So then I have Jacqueline saying it says symphysiotomy is only as a reluctant answer in the exam pro preparation manual. So I guess the manual has been changed from my manual because my manual said absolutely not. So does that answer your question there? Erica, are you still there on the line with me, Erica, or did I lose you?
Yes, I'm here.
Yeah,
Yeah,
okay, I thought I lost connectivity there.
Yeah, it will always be my last
And
thing
it
along
says
with
there, it is
pushing baby.
listed, this there, because I'm getting people typing things, it's listed after Zambinelli. So this is what somebody wrote that up to date says. Jackie wrote this. Symphysiotomy, surgical division of the cartilage of the symphysis pubis, allows the pubic bones to separate, thereby increasing the size of the pelvic opening and relieving the obstruction to delivery. It is rarely used except in remote areas of resource-limited countries where operating rooms are unavailable. Although effective, we recommend avoiding symphysiotomy unless all other maneuvers have failed and cesarean delivery is not possible. If no other option is available, symphysiotomy may be life-saving. The procedure, which is also used to release an entrapped fetal head in breech birth, is described separately. However, the studies in real life show that Zambinelli are very traumatic and have a very high rate of fetal neck injury and demise. The Zambinelli and symphysiotomy are both considered heroic measures.
Those will be my last two. If baby's
In
dying
the
and I have something.
ACOG practice bulletin, and that's from Jennifer. So everybody has something to say about that.
Okay, thank you.
Questions, Erica, but I think you did a very nice job. Because I
No
put you a little bit
questions.
on the hot seat big time because I know your REI. So what are the
That's
big things you should know about is PPH and shoulder dystocia.
Yes, I need to learn my dosing.
Yeah,
Thank you.
but you did good. You did good. You did good. Good job. This is not easy. Okay. So thank you for participating. I think you did a great job, and I appreciate everybody chiming in. And I have here somebody saying some studies show as high as a 40% risk of neck trauma to the fetus, and that's with the Zambinelli. So that's why everybody's chiming in. It's very good information. All right, Erica, anything else?
No, ma'am. Thank you.
All right, great job. Thank you for everybody bringing up these questions and or your inputs. Fantastic. Any questions in regards to this particular topic or topics? I got Rebecca. Rebecca wrote all the stuff with up to date. So thank you, Rebecca, Jacqueline, Jennifer, and Noor, and Ziomara. Thank you so much for, hopefully I included what everybody wrote. All righty, anybody else want to be on the hot seat here? Paul, I'm heading in your direction. Says yourself muted.
Hi,
Are
can
you
you hear
there,
me?
Paula? Yes, you submitted your case list.
I did.
Okay, let's go find it. Do you have any questions with what we discussed?
No, I don't. Thank you, though, for asking.
Are you a generalist?
I am.
Okay. Are you interested in anything specific?
No, just whatever you decide to pull up.
I'm just here looking at your list, okay? I'm just trying to make it bigger so people can see it. Can you see my screen?
Yes.
Case number 19. So you have a patient who had a 7-centimeter adnexal mass. Her CA-125 was normal. So what's concerning in a postmenopausal patient? I'm assuming she was postmenopausal at 58, correct?
Correct. Yeah.
So what is considered abnormal in a postmenopausal woman?
In terms of a cystic mass, I would really be concerned about any adnexal mass in a postmenopausal woman because I'm anticipating that her ovaries are minimally functional at that period. And so really any adnexal mass, especially anything greater than 5 centimeters, I would want to at least investigate a little bit further.
But what is concerning, like what level of CA-125 would be abnormal?
I would say really any elevation of a CA-125 in a postmenopausal woman would be abnormal. I would say over 40.
What if she was premenopausal?
In a premenopausal woman, I probably would be unconcerned unless it was like 200 or greater. But I would still, still investigate. But the threshold for concerning level is higher in a premenopausal
Give me
patient.
2 seconds. Hold that thought. Give me 2 seconds. Are you there?
Yes.
Sorry about that. Somebody was knocking at the door. Kind of
Oh.
strange. Got the wrong place. Is there any concerns that you have in regards to the appearance of the adnexal mass that would make you more concerned?
Yeah, in this particular patient, I did not have concerns. The mass was simple appearing on ultrasound, and I advised the patient that it was almost certainly benign based off of that. But if there were any sort of complex features on the mass, then that.
So what would be complex features?
Complex features would be like excrescences, any septations within the cyst, internal debris, maybe like any nodules or thickened wall.
Anything else?
I think that's mainly it. I guess if the cyst appears solid too, that would be concerning if there's any solid components or calcifications.
So what would make you more concerned? Let's say a 4-centimeter complex mass in a postmenopausal woman, or a 10-centimeter simple clear cyst?
I would be more concerned about a smaller cyst that appears complex than a large simple cyst.
Let's say, is there a certain size that you would be concerned about in regards to a simple cyst in a postmenopausal woman, to be conservatively monitoring that?
Yeah, generally I advise the patients that if the cyst is simple and less than 10 centimeters, then it can be monitored just with surveillance by ultrasound and the patient's symptoms. If the cyst is larger than 10 centimeters, I usually advise the patient to seek surgical management.
So let's say this patient was 16 years old.
Yeah, so if the
What
patient,
tumor? I'm sorry?
no, sorry, I didn't mean to interrupt you.
No, let's say this patient was 16 years old. Let's change your age. What tumor markers would you order and why?
Yes, so if the patient is 16 with a 7 centimeter adnexal mass that's simple, I would not order any tumor markers because she is likely just, ovulatory at that time, and I wouldn't really have a suspicion for malignancy. So I
So
generally
let's say it was a complex mass.
If it was like a solid mass and I'm concerned for maybe like a granulosa cell tumor or sex cord stromal tumor, I would get an AFP and an inhibin. And I would also get a CA-125.
So what would the CA-125 test in a 16-year-old? What type of tumor?
That would be more for an epithelial ovarian cancer. It might also be falsely elevated for an endometrioma. Not falsely elevated, but you would see an elevation if it were an endometrioma.
So you would get it to evaluate for an endometrioma?
I wouldn't routinely get it in a 16-year-old, but I would consider it depending on the appearance of the cyst.
And how often do you get epithelial ovarian cancer in a 16-year-old?
It would be extremely rare.
So would it benefit you to get a CA-125?
No.
What other tumor markers would you get?
Besides an AFP and an inhibin,
and for an inhibin, what's the inhibin evaluating?
I think the inhibin is to evaluate for a sex cord stromal tumor.
Can you be more specific?
Like a granulosa cell tumor.
Okay, and the AFP would evaluate for what?
AFP would be for it's on the tip of my tongue. I'll have to come back to this in a moment because I am not able to verbalize it right this second.
Okay. Anything else that you would order?
For this 16-year-old,
Yes.
I might consider a MRI or a CT scan if I'm actually concerned for malignancy and we're not in the setting of like a suspected torsion.
But what about any other tumor markers?
I don't think that there's anything else that I would order.
Now, in regards to going back to the 58-year-old that you have here, case number 19, how did you perform this procedure?
So this was performed laparoscopically.
Did you include that in your list?
No, that seems to be missing. It was
So be
a
prepared because I can ask you about that.
Okay.
Okay. Let's stop there.
Okay.
Yeah, so I noticed that there's no I'm assuming it was laparoscopic, but it didn't say. So you can't make assumptions. So if they ask you about number 19, you say, you know, it was overlooked, but this case was done laparoscopically.
Okay.
I think you did a good job. CA 125 greater than 200 for premenopausal is abnormal, and I believe 35 usually in regards to the labs for anybody that's postmenopausal.
Okay.
I think you could have added, it all depends how you present your list. Some people say, are of the opinion you should be very specific in the list, saying it would have been a simple cyst or simple appearing or cyst, and some people are of the opinion to leave it open-ended.
Mm-hmm.
So because I'm thinking complex and you brought it up as simple.
Yes.
Does that make sense? But you know they're going to send you to the complex range because that's what they're going to make you do.
Okay.
So you have a dysgerminoma. If she was 16 years old, that AFP and LDH could be elevated. You have an immature teratoma. Usually your tumor markers are negative, but AFP and LDH may be elevated. Your granulosa cell is correct. Your inhibin. Your Sertoli-Leydig tumor is elevated androgens. So to say, I'm going to do a CA125, you're not going to get much yield in a 16-year-old. You're thinking of those rarer tumors.
Right.
So what tumor marker could be elevated in a mucinous cancer?
I think it was CA19-9 possibly.
That and another one that's more old school.
I'm not sure.
CEA.
CEA, yeah, okay.
CEA, and because there's some connection or similarity to intestinal mucosa or GI tract mucosa, supposedly with mucinous. Okay. Other questions?
No, I don't think so. Thank you so much for the line of questioning and for pointing out that laparoscopic is missing. I didn't notice that before.
Yeah, and the key here is not to freak out about it. You know it was overlooked and you encounter it head on, if they even notice it.
Right.
You know, because I always have candidates, oh, I forgot this, I didn't add this, this is going to be really bad, and they get freaked out in regards to their list. You just you had a misspelling or something, if they ask you about that, oh, I must apologize, I spelled, such and such word wrong, if it's
Mhm.
blatant,
Got it.
if that makes any sense.
Yeah, it does.
But good job.
Thank you.
Okay, very good. Thank you for participating. I know we're right at time, guys, but if you're okay, I'm willing to take one more person. I see Rebecca has a question here, or these are the questions from before. Let me just click on that real quick. Yeah, these are the questions from before. I just want to make sure I'm not missing anything here. Yeah, these are the same questions as before. Okay. Anybody else want to be on the hot seat here? I know we're past time, but if anybody else is interested, I got no problem. Ebony, I'm heading your way. Says you're self-muted. Are you there, Ebony?
I'm here.
All right, how we doing?
Pretty good.
All right, let me go get your list here. Are you interested in anything in particular?
You can just pick.
Okay, just pick. I'm just looking. Case number 9. Do you see it? You have my screen there?
Yes.
Okay, so case number 9, can you discuss how you counseled this patient in regards to BSO?
So this patient is a 55-year-old who came to me after having complaints of pelvic pain and pressure. She was diagnosed with a posterior compartment defect, and I had counseled her regarding repair, as well as a hysterectomy. And the patient desired a bilateral salpingoophorectomy as well. I discussed with the patient that doing a BSO or a bilateral oophorectomy wasn't indicated at this time, and that the recommendation would be to keep her ovaries until at least greater than 65. However, she was adamant. She said she didn't want to have additional surgery, and she was definitely terrified of having ovarian cancer. So after continued treatment and discussion on care after surgery, we came to the decision that we would proceed with a robotic hysterectomy, bilateral salpingoophorectomy.
So why specifically is it recommended to keep the ovaries longer in somebody that's let's say 50, 55, 54?
Yeah, so the understanding is that there, with removal of the ovaries, it increases all-cause mortality, and that despite the fact that the patient is menopausal, typically by on average 51, there's still some benefit from keeping your ovaries around.
And what benefits?
So it produces estrogen. They produce estrogen, so it decreases your fracture risk, increases your colon health as well, and decreases your vasomotor symptoms at times.
So when you're menopausal, let's say you're menopausal, it's going to help with your vasomotor symptoms?
Well, you're right. If so, for a patient who is menopausal, it may not necessarily or decrease your vasomotor symptoms, but for taking your ovaries out prematurely, that can cause that to happen.
So let's say you have this 55-year-old who's menopausal. You told her that she's going to have a decrease in she's going to have an increase in osteoporosis, hot flushes. You told her that because she's going to have the BSO?
No, I didn't tell her regarding the hot flashes, but I did explain to the patient that the studies have shown that it decreases, or the understanding is that it decreases all-cause mortality with removing ovaries before the age of 65.
So what studies?
I take back the word studies.
So let's say this patient was younger and was a carrier for BRCA.
Okay.
Can you discuss for me what you would do surgically in regards to doing a risk-reducing BSO?
So for a patient who tested positive for BRCA and desires prophylactic BSO surgery, I would counsel the patient regarding the surgery as well, and the risk associated with it. And I would make sure to remove all ovarian tissue at the time of the procedure, hopefully to reduce the risk of any ovarian remnant syndrome.
So how do you do that? How do you ensure in your procedure that that would occur?
Typically, when performing a BSO, you may go right under the ovary. It would be beneficial to take the ovarian vessels approximately 2 centimeters below the ovary, just to ensure that all of the ovarian tissue is removed.
So 2 centimeters below the ovary?
Mm-hmm. Yes.
Can you explain it in a different way? Because I'm not picturing it.
Inferior along the ovarian vessels.
So where are the ovarian vessels?
So laterally in the pelvis, I guess. Yeah, I don't know exactly what you're asking me.
Because when you take out the ovary,
Mm-hmm.
the vasculature is underneath it. That's what I'm interpreting you're saying.
Okay, I guess it's at an angle. I would be taking the ovarian vessels in the infundibular
What ligament are the ovarian vessels in?
in the infundibular ligament.
So where would you ligate the infundibular pelvic ligament?
Approximately 2 centimeters below the ovary.
I mean, I don't know below is the proper location. Let's put it that way. I do see
Okay.
what you mean, but I don't know if posterior is appropriate.
Posterior.
Is there anything else that you should do in the case?
Not to my knowledge.
would you do anything in the corneal region?
Would I do anything where? I'm sorry.
In the corneal region of the uterus.
If I was just doing the BSO and not doing a hysterectomy,
Right.
I would,
Because you got to include the fallopian tube as well, correct?
yes. Other than just taking the tube and the ovary at that location.
Right. Would you need to do a corneal resection?
You know, I'm not exactly sure. I haven't personally done risk reducing surgery for BRCA, but I'll definitely look into whether or not I need to do a wedge resection.
Is there anything else you should do in the case?
I would, after removing the tissue, notify the team to let the pathologist know that this patient is BRCA positive.
And why would you do that?
To make sure that when they were sectioning the tissue, that they did more sections to evaluate for any cancer or potential concerning tissue.
Anything else you should do?
I'm not sure. Not at this time.
Would you explore the abdomen and pelvis?
Typically with all surgeries I do, just to look to see if there's any other pathology, look at the liver and the peritoneum, see if there's anything abnormal, possibly do washings if there was anything concerning.
Not possibly, you do washings.
I would do washings.
You do washings, yes.
Yes.
All right, let's stop there. Very good, very good. No, it's good. So, just be careful in regards to the BSO. The big issue would be the all-cause mortality increases after the age of, if less than 65, it does not increase after the age of 65. So that's why the recommendation is to keep the ovaries in situ. But they say that the ovary is still doing something, but to say it's going to help with vasomotor symptoms, estrogen, and all that, well, then if that's the case, then why do we worry about osteoporosis in menopausal women? Does that make sense?
Yes.
So usually if somebody is having excess estrogen in their body, where is it usually coming from if they're menopausal?
Adipose tissue.
Exactly. And that's why those gals have the greater risk for the endometrial hyperplasia, EIN, cancer, and so on and so forth. So be careful to say the studies. That's why I asked you what studies, but I think you handled that real good. Never say studies. Never say studies. Okay. So yeah. So
if they push me in there, like other than, so if they push me in there, just like other than all-cause mortality, what's the significance of keeping?
Well, it's usually the all-cause mortality.
Okay.
That's really the big thing. What the ovary's doing, we don't know. It's doing something. Probably our science is not caught up to what the ovary's doing. Sure, one day we'll figure it out. But it's really because what's the major cause of death after menopause?
I guess stroke.
It's heart disease.
Mm-hmm.
So if you say, hey, we take out your ovaries, we increase your cause of death. That's why they're recommending to keep it in place. Does that make sense?
Okay.
Because once women hit menopause, the risk of them having heart attack is MI is just as high as a man, if not higher, supposedly, and women present in a much atypical fashion. Okay. With BRCA positive, you carefully survey the abdomen. You do peritoneal lavage. The ovarian artery and vein should be clamped and cut at least 2 centimeters proximal to ovary and preferably at the pelvic brim to avoid leaving any ovarian tissue behind. The pelvic peritoneum should be opened to visualize the ureter and isolate the ligament and remove as much of the fallopian tube as possible. Now, when I trained many moons ago and they discovered BRCA, the recommendation was to do a corneal resection. And that's why oncologists would do the surgery, because you're cutting into the uterus, bleeding, and so on and so forth. So although the interstitial portion of the fallopian tube is typically left behind after a BSO, there have been no reports of malignant transformation in tubal remnants after this type of surgery. So this is according to UpToDate. As well, the pathology, you got to do more sections because you're looking for microscopic micro-invasive disease. Because with the BRCAs, it can be caught really, they can have a really early cancer that could be completely missed. To my understanding, I'm not a pathologist. So I think the word it better is you want to isolate and identify the ureter. Know that your IP is not in that, the ureter is not in that area, and you want to get the IP as much away from the ovary as possible to make sure that you got all the ovarian tissue out. Does that make sense?
Yeah.
To say posterior, it's more to the side. So I think it's better, a better wording would be IP.
Okay.
Make sure you transect the IP in an area where you know your ureter is not at, because you've identified the ureter. And where does the ureter pass in the broad ligament?
The medial.
Exactly, medial leaf of the broad ligament. So that's where you identify your ureter. You have your ovary, and you want to be well away from both those structures, and you're gonna have a good bite in the sense that you're protected the ureter, and you've gotten enough of that ovary out. Because an ovarian remnant is difficult to remove, very difficult.
Right.
Okay. Other questions? Didn't know I was gonna go in that direction, huh?
Yeah,
But they do that in the exam, so anything and everything's fair game.
Right. I
You
appreciate
did a
it.
good job. Good job on that. Okay.
Thanks.
All righty, very good. So I know we went over, but we got as many people in as we could. I'm gonna put everybody's hands down and see if anybody has any questions about anything that we discussed today. I'm just looking down the line. There's a lot of you on the call here. I'm just gonna see if there's any other questions. It's the same questions in discussion. Okay, I see something here. So yeah, Linda, yeah. So according to UpToDate, there is no need for corneal resection for risk reducing. Okay. No worries. This is from UpToDate as of a couple of years ago. Because like I said, when I trained, we'd had to send them the patients to oncology because that's just hard to deal with that. And the oncologists had a better skill set than a generalist. Any other questions? You can type them in or you can raise your hand. I'm just looking down the line, making sure I'm not missing anybody. I see a hand up. I'm going to Carissa here.
Yes, hi. I just
Yes,
had a quick
Carissa.
question about the
But I know the
age for
answer.
removing ovaries because
Yes.
I feel like I've heard a few different things. I was under the impression that for sure leave ovaries behind until the age of 55, and it's kind of a gray
Yes.
area between 55 to 65.
Yes.
Okay,
But yet the studies
that's correct.
show, and it's kind of like when I first trained, and I don't know if you guys know about this, but when I first trained, anybody less than 40 should keep their ovaries in. 40 to 45 was the gray area, and greater than 45, you got to take them out. The risk of cancer, you want to get that out. So that's kind of what they're doing now. Anything less than 55 is recommended you keep it. 55 to 65 is that gray area. Greater than 65, you can take them out. But then you have to be clear with the patient, because I've discussed with patients, we're taking you to the operating room. You're 57 years old. There is an increase in all-cause mortality, and everybody's like, "What's that mean?" Well, you could have a greater risk of having myocardial infarction or a heart attack. And some patients, you tell them that, they're like, "Absolutely not. Keep them in." You know, other patients, take them out. I don't want cancer. But realistically, what's the greatest chance of death in a woman in the menopause, when they hit menopause? It is heart disease, MI.
Thank you.
So yeah, the gray area is 55, 65, but when you discuss, you know, what the book says, I don't want to say studies, but it's the all-cause mortality less than the age of 65, to my understanding. That makes sense?
Yes.
Okay, very good. And then I see Ziomara has a question. Do you need to retroperitoneal dissection of the uterus? Yes, you want to identify, not necessarily retroperitoneal dissection, but you want to enter the retroperitoneum, like kind of like where the round ligament's at, and you have the ureter in the medial leaf of the broad ligament, and you can identify the ureter, know that it's far away from the IP on that side, and you can very, very safely then clamp, transect, ligature, whatever you're doing, what instrument you're using, and know that the ureter is away from that immediate surgical field of the IP. Does that answer your question, Giomara? I hope it does. If you can just say thank you or yes. I'm looking at what you wrote in the box. I'm just looking to see if anybody else has any questions. Giomara, did that answer your question? Give me a thumbs up or something. Raise your hand. I'm just looking down the line here, guys. Give me a raise of hands, Giomara. Did that answer your question? Can you hear me, Giomara? I'm trying to unmute you to see if you have a question. Can you raise your hand? Did that answer your question? Can you raise your hand, Giomara? It says you're self-muted, so I can't go to you. So I'm gonna lower the hand. Raise your hand again if that answers your question. Oh, your internet cut out. Okay, but yes. Okay, sweet. Okay, cool. All right, very good. So that answers Ziomara's question. I'm just looking down the line. Any other questions, guys? I know we went over, but you know, we're getting close to the date of the November exam, so we want to get in as many people as possible. I think everybody did a great job that participated today. I think we went over some interesting topics. But I don't see there's any other questions. I'm just looking at the box. I don't see any extra questions. I think we've answered everything. One last call. Anybody have a question? Raise your hand. All right, fantastic. I don't see any other questions. I think everybody did a great job. Thank you, everybody, for their questions and for participating. I think everybody else on the hot seat did a fantastic job. These are not easy topics, but important topics that we need to know for the exam. So I wish everybody a good evening and a rest of a good week. And we'll talk to you on the next webinar, which will be tomorrow, which will be structured cases. Have a good night, guys. Thank you so much.